Okay, started recording. Okay. Okay, do you guys see my screen?
Yes, yes, please.
Okay, sounds very good. Okay, so what is acutely ill child? Acutely ill child who has a prone or has a cardiac arrest. This cardiac arrest can start with a problem. Usually the problem is either respiratory or cardiac. So what happened is either we have respiratory distress, then cause failure, or right away we have respiratory failure, cause cardiopulmonary compromise and leading to cardiac arrest. Or we have a circulatory problem causing shock, leading to cardiopulmonary failure and then cardiac arrest. Or right away we have a rhythmic problem causing cardiac arrest. So the endpoint is the cardiac arrest, but it can be respiratory, it can be circulatory, and it can be arrhythmic. Now, the sudden cardiac arrest is very uncommon in children. And if it happens, it's usually either due to VF or VT. And the respiratory problem can cause right away respiratory failure, but sometimes start with respiratory distress. Now, respiratory failure without respiratory distress occur when a child failed to maintain an open airway or adequate respiratory effort, typically associated with loss of consciousness or obstruction of the airway. So this is the pulse algorithm of the initial resuscitation, which we will depend on when we assess a sick baby. So you can see that at the beginning, you look at whether the baby is conscious, breathing, and then look to the color. So then you divide the child is either responsive or unresponsive. And if the child is unresponsive, either he or she will be with breathing, not breathing, but sometimes they are gasping, and we will define what is gasping later on. And then you go with the algorithm, you evaluate. So you do evaluate, you identify, you intervene, evaluate, identify, and intervene. And if the child is unresponsive with or without, gasping or without gasping, you need help. And then once you ask for help, you assess whether the baby is with pulse or without pulse. And then we need to define what is with pulse and what is without pulse. And then you decide whether to do CPR or do the evaluation, identification, and intervention. Now, when we do initial assessment, we should be very quick. We should do initial visual and auditory observation, and this should take seconds. And then you divide these patients to two main domains, consciousness and breathing. In consciousness, you don't need to do much. You just need to say if the baby is unresponsive or irritable, fugue, restless, or alert. And then you need to assess the breathing. Either there is increased work of breathing, or there is absent or decrease respiratory effort, and or there is abnormal sound heard by stethoscope. So these are usually your quick first assessment. So you assess consciousness, you assess breathing, and then you need to assess the color. Is it cyanose? Is it pale or only mottling? When the baby has decreased level of consciousness, mostly there is either inadequate oxygenation or inadequate substrate delivery or birth trauma or brain dysfunction. Inadequate oxygenation that lead to level consciousness is, we call it desaturation. Inadequate substrate that cause decreased level of consciousness, example, hypoglycemia. Or if you can mute yourself, please, iPhone. You don't have name and you're opening your mic. Okay. While abnormal breathing is either you are using accessory muscle, which means you have difficulty in breathing, or you have extra sound, such as snoring, wheezing, or you have abnormal breath pattern. So remember these things: consciousness, breathing, color. Consciousness that altered are for these reasons, and abnormal breathings are these findings. The color is either pale, mottled, bluish, or gray. When you see this, mean poor perfusion, poor oxygenation, or both. When you see flushed color, hyperemic patient is either fever or toxin, snake bite, medications, environmental exposure, whatever causing you toxin, causing you flush. When you do the assessment, it's a three parts: evaluate, identify, intervene. What evaluate means? Evaluate in sick child is two types. There is primary assessment, there is secondary assessment, and there is diagnostic test. So when you evaluate a sick child, we have a primary assessment, we have secondary assessment, and we have diagnostic test. In the primary assessment, we do A, B, C, D, E, and F. These include respiratory, cardiovascular, and neurological system. In secondary assessment, we do ample, and we will speak about what amples mean, but it is a focus history and focus examination. In diagnostic test, we do laboratory, radiology, and we might ask for advanced test. The point of this is we do it when the child is unresponsive, is responsive, is breathing, and he has heart rate. So we do this evaluation. If the child is unresponsive or not breathing, or there is no pulse, then we do CPR. However, if the child is breathing and has pulse rate, we do evaluation, identify, intervene. How we do evaluation? Primary assessment, secondary assessment, diagnostic test. Any questions so far? Anybody has any question? Yes? No? Okay, no comments. That is not good way of learning.
Thank you. It's clear.
It is clear. Great.
Thank you.
When we identify. Remember, these babies are breathing and not gasping and have pulse rate. So what do you identify? You identify the respiratory, cardiovascular, cardiopulmonary failure, cardiac arrest. In respiratory, we need to know, is it upper airway? Is it lower airway? Is it lung tissue disease? Or it is the disordered controlled breathing? Is there is respiratory distress or there is respiratory failure? In cardiovascular, so once upper airway or it's lower airway, lung tissue disease, disordered controlled breathing, we have to decide respiratory failure or respiratory distress. In cardiovascular, we decide hypovolemic shock, distributive shock, cardiogenic shock, obstructive shock. In some time, it's a combined. So the final diagnosis, is it compensated shock or hypotensive shock? Or the child from both in cardiorespiratory failure, or actually we have a cardiac arrest. We can have a combined, and remember, one can lead to another. And we always will have uncertainty about the type and the severity. So let's repeat what we said. You go first, your initial response. 3, consciousness, either unresponsive, irritable, or alert. Breathing, either increased work of breathing, absent or decreased respiratory effort, abnormal breathing sound. Color, cyanosed, pale, mottled. You answer this question. So if the child is unresponsive with no breathing or gasping, then go CPR. If the child breathing, but the pulse is not there, go to CPR. If the child is responsive, breathing, and has heart rate, then go evaluation, identify, intervene. When you evaluate primary assessment, secondary assessment, diagnostic test. Primary assessment is A, B, C, D, E, F, including respiratory, CNS, and neurological. Secondary assessment use the anonym of AMPL, which means focus, history, and exam. And diagnostic test includes laboratory, radiology, and other advanced tests. And so when you do evaluate, you identify. So you identify either respiratory problem, cardiovascular problem, or both. Or we are actually in a cardiopulmonary failure, or actually we have cardiac arrest. In respiratory, you need to say, is it upper airway, lower airway, lung tissue, or disorder of controlled breathing? And then whether the child in respiratory distress or respiratory failure. In cardiovascular, you need to see, is it hypovolemic, distributive, cardiogenic, obstructive? And then you need to decide whether it's a compensated or uncompensated. Remember, it can be combined. One can lead to another, and you always have uncertainty about the type and about severity. Any question? Now, if the child is unconscious, not breathing, and no heart rate, and you start CPR, you have to continue until the child regain spontaneous consciousness. Once you do CPR and the child regain consciousness, go to this algorithm of evaluate, identify, intervene. If the child is breathing, go to the right way. If the child is conscious, go to this way. If the child has heart rate, go this way. If the child has no, go to start to CPR. If you start CPR and the child regain consciousness, go back to this algorithm. Any question?
Sorry, what do you mean by distributive shock?
Distributive shock is usually happen in many scenarios. One of them is sepsis. Second one is prematurity. Third one, when you have toxin. Distributive shock, when you have discrepancy between the heart pushing and what actually reaching to the patient. So the heart is actually functioning, but it's not reaching to the tissue. That's what we call it. We will talk about it in details, in boring details, but this is just a list right now.
Okay.
Okay. So when we say intervene, so remember we said evaluate, identify, and then intervene. So when we say intervene, in respiratory, we position, we give blended oxygen or ventilatory support. We might give nebulizer or inhaler, depend on the situation. In cardiovascular, you do CPR, you give cardiac monitor and pulse oximetry, and you need a fluid. So these are intervention. In addition to this, now if you have a code in your hospital, you have to activate the code or activate the emergency response, whether it's a blue code or neonatal blue or pink code, whatever the code is named, or the code for obstetric or for trauma, what is that? And then, of course, when you have code, you should have a rapid response team, and you have a code or a code cart where you have all the medications and the supplies and the procedures that needed for the intervention in one cart that you can push it. And you should have also monitors that you can move it so you can take care of baby. And also part of your intervention is what you do for cardiac arrest, which is the CPR. So remember, it's evaluate, identify, intervene until we are stable. Identify, evaluate, identify, intervene should be before and after each intervention, or the trend is change. And when you identify, it's very vital to say, is it life-threatening or not life-threatening? When it's life-threatening, we are here. When it's not life-threatening, we are in this circle. So what is life-threatening conditions? Absent or agonal respiration. And we will define all these. When you have respiratory distress, when you have cyanosis, and when you have change in level of consciousness. Now you have to repeat the evaluation, identify, and intervention after each intervention, or when the trend change, which means the baby improve or deteriorate. So remember we said the identification composed of primary assessment, secondary assessment, and test. And remember we said primary assessment include airway, breathing, disability, and E. So A, B, C, D, E, and some people include F we will be talking about. But right now we will be talking about the primary assessment one by one. So let's start with the airway. Airway, when you decide about airway and you do primary assessment, you need to decide whether it is. Can you mute yourself, please? So just unmute yourself when you want to talk, but mute yourself when you don't, because, or you need to use your mic headset, or you go to a quiet room. Okay, so when you decide the airway, you need to decide, is it patent or not? And is there movement of the chest and or the abdomen or not? And you need to listen to the air entry and breath sound. So once you evaluate, you need to identify. So when you evaluate the airway, your identification is the 3 words: clear, maintainable, not maintainable. So let's go back. So you have baby, you did your primary impression by listening and looking. You decide the child breathing, not breathing, conscious, not conscious. And if he's breathing, has pulse or has no pulse. If not breathing, unconscious or no pulse, you initiate your CPR. Otherwise, you go in your intervention, evaluation, identification, intervention. If you decide to do CPR, you continue until the child regain consciousness and spontaneous breathing, and then you go to the other cycle. When you intervene, it's a primary, secondary, and diagnostic test. In the primary assessment, we have A, B, C, D, E. In A, it's airway. So you look if the airway is patent or not, if there is chest movement or not, and if there is good air entry, or there is air entry or not, and whether there is other sound. And then so this is your evaluation, and then your identification. Clear, maintainable, not maintainable. Now, clear mean open, non-obstructive. Maintainable means can be opened by simple measure, such as head tilt, chin lift. Not maintainable mean need intubation. So this is your primary assessment, this is your identification, and this is your intervention. Any question so far? Okay, no question. When we say intervention, sometimes simple measure can deal with airway, such as position of comfort. So you might put the baby on the child on the lateral side, put neck, you might need to support the neck or the head. You might need to open the mouth. You might need to do head tilt and chin lift. In a trauma, you cannot use head tilt, chin lift. You might need to use jaw thrust. So all these terms, we'll discuss it in details, by the way. You need always to avoid hyperextension. Avoid suction. Do not suction. Suction is wrong. Suction is unnecessary. Remember that. Do not suction. Suction is wrong. Suction is not necessary. Suction is not part of resuscitation. Suction is needed only when you give respiratory support and no chest rise. And second, when you want to intubate and you cannot see the airways. That is the only indication of suction. Suction is not part of resuscitation. So please avoid suction of the nose and oropharynx. Do not spend time and waste your time in doing this. Okay, when you need to suction, if any, suction the mouth. Do not suction the nose. Suction, do not go to the pharynx. Just suction the mouth. When you see that the child is breathing, but there is no chest rising, and you suspect foreign body, you have to perform something called FABAO, and we will speak about it later. You can use airway adjunct, such as nasopharyngeal airways or oropharyngeal airway. When you want to perform FABAO or foreign body removal, depending on the age, if less than 1 year, you do 5-bag slabs and chest thrust. And if you are more than 1 year, you have to do abdominal thrust. When we say advanced intervention, we mean ETT, CPAP, we mean laryngoscope. We might also do cricothyrotomy, whether by needle or by surgical intervention. Any question about airways? Do you guys like it? No? Yes? Anything?
Yes, of course.
Great, because everybody's keeping
Yes,
silent.
teacher.
Remember, whatever your intervention is, positioning is vital. Positioning the child or the baby is vital. So we finish with the primary assessment of airway. Now we will assess the B, or breathing. When we set the breathing, we assess the rate, the effort, the expansion, the movement of the air, sound, oxygen saturation by pulse oximetry. Again, rate, effort, expansion, movement of air, sound, and oxygen saturation. Heart rate, respiratory rate. If less than 1 year, the normal is 30 to 60. Not very true, but mostly true. In toddler or 1 to 3 years, the normal 24 to 40. In school age, it's somewhere between 18 to 30, and more than 13 is usually an adult limit between 12 to 18 cycle per minute. When we count the respiratory rate, it should be over 30 seconds, and then we multiply it by 2. It's better to count it more than one time and use a monitor to monitor the rate. Remember, don't look to the instant number, talk the range number, because instant number is counting based on one cycle, which is the time between 2 cycles, and 60 divided by the time between 2 cycles give you the respiratory rate on the monitor. So don't look if the 60, that means 60, and then it can be 20. So always take the range when you look at the monitor. And when for purpose of primary assessment, we do not need a true number. We just need above 60, mean tachypnea, or below 10, mean bradypnea. And when it's above 60 and below 10, it's always abnormal in any patient from newborn till elderly. Now, remember that when it's more than 60, it's called tachypnea, and it can be for simple reasons, such as fever, pain, or if you have metabolic acidosis, such as when you have dehydration or diabetes. Or it can be sepsis or heart failure, severe anemia. And please remember, when you write severe, put E, because without E, it's sever, cut. People always missing E. Some cyanotic congenital heart disease can cause tachypnea, and medications can cause tachypnea. Okay, this is not bradycardia. This is bradypnea. This is a wrong spelling. So sorry about that.
Using the device audio دي بس سمع كده مرة شو واو سمع كده يعني لسه سمع كده بخشين بدنا سوي بخشين بدنا هاي بخشين مو أمابت وهاي بخشين هيتي
Abdullah Kamal Ghafoor, sorry, I muted you because everybody is listening to what you're saying. So when you have a low respiratory rate, it can be muscle fatigue, it can be central, it can be infection, it can be hypothermia, medication, severe anemia again can cause it, some cyanotic, and usually when you have bradypnea or respiratory rate below 10, it's usually a very serious sign. Remember apnea, when you say apnea, and that's why always I like my physician working with me, don't say apnea, say no breathing or low breathing effort. But once you say apnea, it's a very clear diagnosis. It's cessation of breathing for 20 seconds or less than 20 seconds associated with desaturation. And when we say desaturation, that we are meaning not the dips, means saturation goes below 85%. or sometimes associated with pallor. And remember that cyanosis can be central. Sorry, the apnea can be central, can be obstructive, some be both of them. Any question about breathing? When we say agonal breathing, we mean, or a gasp, we mean there is a breathing, but without actual change of gas. So there is movement, but there is no actual gas going to the alveoli and exchanging with the blood. So there is no oxygen improvement. That is what's called agonal gasp. Usually they are irregular and they are without effective ventilation and or oxygenation. So remember, we said respiratory rate. That is our first assessment. Remember, we said respiratory rate, part of the briefing. So all talk, this was about the respiratory rate. Now we will be talking about respiratory effort, our primary assessment of breathing. Remember, we assessed the airway, and now we're assessing the breathing. So respiratory effort, when we say respiratory effort, either we have increased resistance, so a problem in the airways, such as asthma and bronchiolitis, or we have a stiffness, compliance problem, such as pneumonia, edema, effusion, or sometimes we have non-pulmonary problem, such as DKA or salicylate poisoning or inborn error of metabolism. Now, how we assess the breathing, we have nasal flaring, or we might have retraction, such as can be subcostal, can be substernal, can be intercostal. I want to stop here, actually. I want to do breathing effort in the second episode. I think I'm taking more time. So let me stop if you guys have any question. Anybody has any question?
Doctor,
Yes, go ahead, mom.
please, I don't understand agonal breathing.
Agonal breathing, or بالعربي, I don't know what's called in Kurdish, but بالعربي is يعالج. سمع واحد يعالج قبل الموت؟
يعالج قبل ايه
سامعة بالكلمة ده يعالج يقولون الناس؟
طبعا ايه سامع.
This is agonal. يعالج mean agonal. Agonal is a breath that is first irregular, second without effective ventilation, and without effective oxygenation. So it's a movement, but there is no breathing. There is no exchange. There is no ventilation. But when we say ventilation, we always mean CO2 exchange. And when we say oxygenation, we mean oxygen. So you see the baby or the child is breathing, but actually there is no gas exchange. There is no ventilation. There is no oxygenation. So I don't know what you call it in Kurdish. You can tell me.
I don't know.
Anybody knows what is called in Kurdish? In Arabic, ما أدري أعتقد سرمد يحكي عربي صح؟
يعني دكتور بالعربي انه
I think in Kurdish we can say it is Gyanayat. Gyanallah.
Gyanallah. العربي عالج, or in is agonal.
Yeah.
تمام.
Gyanallah. Okay, well, that's good that I know this word. Any more questions, please? Ask me.
Sorry, for how long should we do for the duration?
Sorry, again?
How long should we do CPR for a patient if has cardiopulmonary arrest? The duration.
We will talk about it later, but it is 20 minutes. 20 minutes from last recorded heart rate. 20.
Yes.
We used to use 10 minutes, but now they've changed. 20 minutes from last recorded heart rate. But we will speak about the ethical background of resuscitation and caring of sick child. and depend on the state, on the religion, on ethnicity, on the background, whether you have difficult family members, aggressiveness. There are many things to consider. But according to the literature, the outcome, if you don't have heart rate from 20 minutes from last recorded heart rate, then, and if you arrive and you don't know when the heart rate was stopped, it's the time you assess. So 20 minutes from the, not from the arrest, 20 minutes from the last recorded heart rate or the time of your assessment.
Thank you very much.
Thank you. Any more questions?
Sorry, Isa, one question.
Yeah, go ahead.
Regarding those with the arrest, cardiac arrest.
Yeah.
Starting with the airway breathing circulation or start from the circulation?
No, they're changing the line. They change from.
If it is arrest, cardiac, and pulseless,
Yeah,
sometimes
so we used to do ABC, but now we are using CAP. We used to use APC, but now we are using CAP. Now this is depend on newborn or a child, because newborn resuscitation is ventilation, 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 and then heart. Because in a newborn is everything about ventilation, because we rarely ever have a cardiac arrest in newborn babies, and it's very uncommon in children, but it's more common than newborn. So because of that, if you are more than 1 year, it's better to do CAP, but if you are a newborn, then it's ABC, I think. So because in newborn, we depend on NRP, while in children, we do an pulse. And now if you ask me, what is the line it's of separation between NRP and pulse or PLS, it's very hard to say, but I would say 3 months. But it's not, there's no evidence of saying 3 months. I'm not, it's a literal number that I mean, it's an arbitrary number, sorry, that I'm using. But I would say less than 3 months do ABC, but more than 3 months do CAP.
Yes. C, you mean by checking by the DC? Circulation, yes. But they say put the DC. Put the DC and monitor through that.
Who said?
In the guideline, for example, sometime might be the case VT. And you don't know it's VT.
It depends. It depends on the age. So, but yes, you can use the DC as a monitor. I agree with them. But don't give the DC. It depends. We're using it as a correct.
Give the DC. Not mean give the DC. Monitor by DC.
Because we have cardioversion.
Yeah.
And we have DC shock, right?
Yeah, right.
You know the difference? We will talk about it when we go to the heart. We're just in the airways, and we said breathing, and in the breathing we assess the respiratory rate, and we're start to assess the breathing effort. So if we can stick to this, that would be great. But we will talk, because it's 300 slides. We only took 35, so it's a long session. Yeah, it's a long session. It will take everything in details. But do you guys like it, or should I continue, or not necessary? You go and know this information. I don't know. Maybe you know the information, and I'm giving you something.
We need this info.
If you need me, I can continue, but I can give you another things. I mean, but it depends on your needs. So if you can discuss in the group, I will also give you the record. And if you can continue discuss in the group whether you want me to continue, what exactly you need, because this session based on what I practice, but I don't know exactly what's your practice in reality. So you can decide exactly whether we can go with this series or, changing to something else.
My opinion to this series. I don't know the other opinion.
Yeah, we can discuss it in the.
Let's continue, Dr. Yahya. What you want and what you see important for us.
Great.
Yeah, this is
Inshallah.
great because we usually practice this, and this is how we practice. And knowing these details are really essential for us. You know, the limits, the
Okay.
borderlines, and
So I have a question. Why you guys don't open the camera? Because women in Iraq, they don't share their now, or because you are not ready? I don't understand. But it's way better to open the camera so we have like a mutual conversation. You see me, I see you. At least the person who's talking.
Sorry, doctor, I can't open the camera because some of us, female, we are
Oh,
hijab.
I see. Okay, sorry about that. Sorry. I didn't mean to be rude. Yeah, okay. But also the men are, anyhow, don't worry. But it would be great if we have a mutual, like I see you, you see me, and then we can have it. So any more questions, however, any more questions? Okay,
Thank
so
you,
I'm gonna
Doctor.
pause the video record of this session, and inshallah next Wednesday we'll continue the session. And I think we need 5 sessions to finish all the series. And then once we finish, we will go to resuscitation of newborn baby. And once we finish, I'm gonna give you important topics such as nebulization, inhaler, IV fluid, antibiotics, things that is common that you will face, and how to select antibiotics, how to select fluid, how to treat hypotension. What other sessions you guys like? Transport, what you do with transport, intubation. We already did the workshop about ventilation, but also we can talk about nutrition, total parenteral nutrition, like these essential central lines, how to do central lines and how to take care of central lines.
And Doctor, you promised us for the ultrasound of lung, if it's possible for you.
Do you have lung ultrasound? Do you have can you do the lung ultrasound? Do you have the machine?
Yeah, we have the machine, but we have not the practice.
But you are allowed to use the machine, or the radiologist prevent you? Or
at least in neonatal department, at least.
Okay, but you have the machine and you can use it, right?
Yes.
Yeah.
Yes.
Okay, so right now I'm giving a course to hospital in Al Ain called Kanad Hospital. I'm giving them a course about lung ultrasound. They are 9. They are 7 neonatologists and 2 radiologists. And then I will go one day to the Al Ain to give them hand-on. So what usually I give is, but this is paid course, of course. So also once I finish, I will them cases, and then I will do and give hand-on. So if you guys want it for free, I can do that. But if you want it paid and you want a certificate, I can do that all. But if you want it for free, there will be no certificate. Clear?
yeah, yes.
Yeah.
Yes.
So if you guys have more questions, we'll be happy to answer. And if not, we can end the session.
Sorry, Dr. Yahya. At least
Go
we
ahead.
can half hour. Since the session is too long.
Oh, is it? Is it? Yeah, sorry, because the questions are too much. I will only give 25 slide next time. I'll make it as short as possible. Sorry about that.
We can continue. I say we can continue.
Is it? Oh, is it? Okay, 1 hour now. I think 1 hour will be more boring. I don't know how you feel, but yeah, 1 hour. Yeah, we'll make it 1 hour. So we'll give 45-minute session, and we'll make 15 minutes for questions and answers. But we can change whatever you guys like. I have no problem. I can continue talk for 3 hours. You already was with me. I continue to talk the whole day. So I have no problem, but it will be boring. You'll start to yawn and you start to. So, I mean, I think 45 minutes is good, 15 minutes for questions. But we will continue the series and we will change depend on your need. Okay?
Okay, thank you.